to the Neuroscience Cafe. And the Neuroscience Cafe is really offered to you by the UAB Comprehensive Neuroscience Center, or the CNC. So, right. So this it's a virtual network of people who are interested in neuroscience at UAB. So there's about 500 people, including faculty, clinicians, staff, and students. And it's throughout the UAB, throughout the different schools. So it spanned 9 schools and 32 departments. There's a lot of neuroscience to attract and share. So we used to have monthly Neuroscience Cafe at local libraries in the Jefferson County. However, with COVID, we had to change. And we had started to do those virtual Neuroscience Cafe. So this is what this is about. So our mission is really trying to promote research and translation of research into clinical neuroscience. And our vision is a world where the mysteries of the nervous system are solved. This is the most bizarre thing. So I'm Adrienne Latti. I'm the director of the CNC. I'm a professor. I'm the chair of the Department of Psychiatry and Behavioral Neurobiology. The co-director is Lucas Pozzo-Miller. He's a professor in the Department of Neurobiology. And then associate director is Lauren Sinsich, who is he's from the Department of Optometry Vision Science. So today we have 2 excellent people who are going to speak about anxiety and stress disorder following traumatic medical events. It's really a treat. I've known Dr. Knights, both of Dr. Knights for a long time, and they are really, really fabulous people. So David Knight is a professor in the Department of Psychology, and he's also the director of the Behavioral Neuroscience PhD program at UAB. That means that he takes care of a lot of graduate students. His research is focused on understanding the neural substrate of human learning, memory, and emotion. And it's especially interested in understanding emotional regulation using brain imaging techniques. So he has published a lot of papers on that, and he's going to share some of those. Hey, I have it up. What are you doing? Okay. So Dr. Amy Knight is an associate professor in the Department of Physical Medicine and Rehabilitation, and she's also the division director of rehabilitation psychology at Spain Rehab at UAB. She's board certified in clinical neuropsychology. She works with patients on the stroke service. She also do assessment, neuropsychological assessment, and she also offers psychotherapy to support coping and adjustment to neurological disabilities. So this is really a treat to have them tonight. And I'm going to tell you about the next one coming. So this is on June 17. Charlene Newsom from the University of Alabama will be speaking about the relationship between spatial processing and math. And then we have another person on July 15, Dr. Houston, speaking about concussion. On August 19, we have Drs. Uzwate and Loken speaking about brain fog after COVID. September 16, Dr. Zaplarski was going to speak about medicine and cannabis. This is really important in view of what happened this week to cannabis legislation in Alabama. And then October 21, we have Dr. Amara and Alan Dorfer speaking about exercise and neuro disorder. And finally, in November, two doctors from the University of Alabama also speaking about science can help us to understand math. So I'm going to stop there, and I'm going to let Dr. Knight sharing his screen.
All right, can you hear me okay?
Yep.
All right, so thanks, Adrian. I'm looking forward to telling everybody a little bit about some of the things that Dr. Amy Knight and I have been working on for the last few years. So to get us started, imagine this scenario. You are in your car at the end of the day, you're on the highway, maybe you're driving home after work, and you're making pretty good progress in traffic, and slowly the sun starts to set and some bad weather comes in. Worsening road conditions, maybe making them a little bit slick. You and other traffic around you starts to slow down just a little bit. You're all being cautious and safe. And then you look in your rearview mirror and you see a car speeding up behind you. Now, this is one of those cars that likes to dart in and out of traffic, doesn't use their blinker, zooms in and out between cars, cuts other cars off, and you see him coming, and you, being the cautious driver you are, decide that you're just going to get out of their way. And so you quickly turn on your blinker, start to change lanes, and at just that moment when you're shifting over into the other lane, the car behind you shifts into that lane too, guns it, and tries to get around you. And they clip the tail end of your car, send your car spinning, and as you're spinning, you see other cars around you rushing towards you. And your life flashes before your eyes. You start to worry very quickly about the harm, the serious harm that might come to your body. You realize that you might die. You're having intense fear, heart's racing, having trouble catching your breath, sweating profusely. And as all that's happening, you start to hear tires squeal, metal bend, and glass break. And instinctively, you close your eyes, not wanting to see what's going to happen. And slowly, your car comes to rest on the side of the road. And it's in pretty bad shape. But fortunately, in this example I'm offering, you were wearing a seatbelt, your airbag's deployed, and you're okay. All right. But you're shaken, maybe you're a little bit stirred, and but you're okay. Now, these kind of events are some of the prerequisites for developing post-traumatic stress disorder. You've had a traumatic event, you've had intense fear, you've had fear of serious bodily harm, you've had fear for your life. And these events can lead to post-traumatic stress disorder or PTSD. Now, certainly a car accident is one of those events that can elicit PTSD, but so are a whole lot of other things. Most of us are probably familiar with it in terms of soldiers returning from war zones like Iraq and Afghanistan. You can imagine it from civilians that are in war-torn areas where there is frequent conflict. But some of the places you might not consider it quite as much is maybe at the workplace. Factory workers might get limbs caught in machinery. They might have machinery or equipment tumble over and pin them against the wall or the floor. They can experience chemical burns or electrical burns with the equipment that they're working with. There are all kinds of accidents that often happen at work that can produce bodily harm and PTSD. Certainly there are accidents that can happen in the home. You might think of fire as being one of those. But not only can the individuals who are the victims of these accidents suffer PTSD, but the people trying to help them can as well. When we think about first responders, people like police officers, firefighters, EMTs, they also can develop PTSD simply by witnessing traumatic events that other people have experienced. So these are all ways that people can experience traumatic events that may lead to post-traumatic distress disorder. And some of the symptoms that these individuals might encounter are things like intrusive thoughts, avoidance behaviors, negative thoughts and feelings, hyperarousal, extreme emotional reactivity. And some maybe more specific examples of each of those are when we think about intrusive thoughts, those might be recurrent, involuntary, distressing thoughts or memories. They might take the forms of nightmares, and they're usually triggers for intense physiological emotional reactions. For avoidance behaviors, it might be these individuals not wanting to talk about the traumatic event. It might be them trying to suppress memories and thoughts about those events, or avoiding places where traumatic things have occurred. With negative thoughts and feelings, that might take the form of depression. Some individuals will experience guilt and shame about the events that occurred. And there can be detachment from reality and distorted cognitions around it. And certainly there's the intense emotional reactions that might take the form of exaggerated startle responses or hypervigilance in the environment, as if there's always a threat to be watching for. Emotionally, you might see outbursts of anger. These can drive attention problems and difficulties with sleep. And so those are some of the symptoms that we're interested in understanding with the research that we've been working on for the last few years. Now, every year, there are approximately 25 million people that experience a traumatic event. And about 60 to 70% of us will experience a traumatic event at some point in our lifetime. Now, fortunately, I don't know if that's the right word, but I'm going to say fortunately, most of us don't develop PTSD. Only about 20 or 30% of people exposed to a traumatic event ultimately develop post-traumatic stress disorder. The other 70 to 80% might experience some stress, some distress, but ultimately over days and weeks, they recover and there are no long-lasting effects of the trauma. Now, these kinds of facts lead us to a few questions that we might answer as neuroscientists. For example, can we identify the neurobiology that distinguishes those people who are susceptible to PTSD from those who are resilient to it? Can we use our studies to understand neurobiological differences that might promote susceptibility or resilience versus what are the brain regions that might change as an effect of experiencing PTSD? And can we identify the difference and understand the difference? Maybe there are regions or processes where both are the case. There might be a predisposition, and then the post-traumatic stress might make that condition worse. We're interested in chronic effects of traumatic stress, as well as acute effects. We would like to be able to study the trajectory of change over time, looking at neurobiological processes that change immediately after a trauma and following that change maybe at 3 months, 6 months, a year down the road. And can we use that information to understand perhaps things that are happening acutely, immediately after a traumatic event that might help us predict long-term outcomes? And if we can we use that to help identify those individuals who might benefit the most from early intervention? So those are questions that we have. We're not able to answer all of these right now, but these are things that we're thinking about with our research. Now, in my lab over the last 15, 20 years, we've been trying to understand the neural circuitry that supports important emotion processes. Some of this in just healthy individuals. We just want to understand how it works in the healthy brain. And so we've been studying things like fear learning and memory, emotion expression, and emotion regulation. And the brain regions that we see on the screen here are regions that we think are really important for these kinds of emotional processes. I'm going to start by talking about the region in red, and that's the hippocampus. And if Larry Verhoff's here, I want him to notice that this is a rather bumpy hippocampus. So the hippocampus is in red, and it's important for forming long-term memories. And in terms of our research, what we think is that the hippocampus uses its information about long-term memories to form expectations about threats that are imminent, threats that are going to occur in the next few seconds, next few moments. And it passes that information, that expectancy, onto a region of the brain shown in green here called the dorsolateral prefrontal cortex. This is a region of the brain that supports working memory processes. That's the kind of process that keeps information online and active while we're working with it. And in terms of our research, we think it's really important for anticipating future threats, and that anticipatory information is then passed forward to other brain regions and modulates the activity in those brain regions once a threat actually occurs. And one of those brain regions is the dorsal medial prefrontal cortex, shown in purple here. It's a region of the brain that's important for attention, for error detection, which is important for learning and memory, and some forms of emotion regulation. And so the anticipatory information from the dorsolateral prefrontal cortex in green modulates the dorsal medial prefrontal cortex's activity, which is shown in purple, when that threat actually occurs. And then that information is passed along to the ventromedial prefrontal cortex, shown in yellow. It's a region of the brain that's really important for emotion regulation. It regulates the activity of the amygdala, shown in blue. And the amygdala is a region that we think of as being really important for fear, learning, and memory, and emotion expression. It projects to other brainstem regions that directly control things like changes in heart rate, changes in respiration, or sweat gland activity. So this is the basic neural circuit that we've been looking at, trying to understand how it supports normal, healthy learning and memory processes, and what might be dysfunctional in this circuit for people who suffer from PTSD. Now, in some of our most recent research, we've been focusing on a few types of brain imaging that allow us to ask different questions about the brain. We've been studying brain function. We've been studying brain structure, in particular related to white matter tracts. And we've been studying the biochemistry of the brain. I want to tell you first about some of our work looking at the function of the brain. One of the things that we do in my laboratory is study fear conditioning. Some of you will be familiar with conditioning from the work of Pavlov and his dogs. And just to quickly remind you, Pavlov's the guy who would ring a bell, give his dogs food. The dogs salivate when they get food. But what was interesting is that over time, the dogs learned that the bell predicted food. And so they would start salivating when they heard the bell alone, in anticipation of receiving that food. Now, we can do similar things with humans using fear conditioning. We don't use bells and we don't use food. Instead, we use tones and we use loud, aversive static sounds. So in a typical study, we might present a tone, let's just say it's a high-pitched tone, and we might pair that high-pitched tone with an aversive, loud, static white noise. So a loud static white noise might be that sound that your car radio or your TV gets when you lose reception, that snowy, crackly sound. And if you play it loudly, people find it unpleasant or aversive. And so this high-pitched tone would serve as a warning signal. It warns participants that this aversive noise is coming in a few seconds. So we can look at warning signals in the brain, the way the brain responds to it. We can also look at safety signals, which might be a different tone, let's say a low-pitched tone, and that low-pitched tone would be presented without the loud static noise. And so we can see how the brain responds to warning signals of threat and safety signals that tell people that a threat's not coming. And when we look at the brains of people who have been exposed to trauma and the brains of people who haven't, we find that there are no differences when we look at the warning signal. The brains of people with PTSD respond just the same way as healthy controls who don't have PTSD to the warning signal. What's interesting is when you look at the safety signal, what we find is those people exposed to a trauma show much greater brain activation in this region shown in yellow. They show greater brain activation during the safety signal than healthy controls do. And you can see the difference in that in this graph down below, where those exposed to a trauma show greater activity in these areas in yellow, while controls that haven't been exposed to a trauma show less activity. So what that tells us is that there may be a deficit in safety learning in people who develop post-traumatic stress disorder. They're treating their entire environment, whether it's safe or not, as if it's threatening. So they over-respond under safe conditions. They don't seem to know in some ways that a safe condition is really safe. So we would call that a deficit in safety learning. I'm going to move on to a different type of imaging that we often work with, which is diffusion-weighted imaging. And it allows us to look at the white matter tracts of the brain. White matter tracts are basically the wires, the connections between these different colored brain regions that you see on the screen. So basically, you can imagine the black arrows as being white matter tracts that connect one region to another. And we've identified 3 different white matter tracts that we're really interested in. One, shown in purple here, is called the Cingulum Bundle. It connects dorsal regions of the prefrontal cortex, which would be up here, to more ventral regions, which would be down here. The white matter tract in green is called the Unsonic Fasciculus. It connects ventral regions of the prefrontal cortex to the anterior temporal lobe, where we find structures like the amygdala and the hippocampus. In yellow are 2 white matter tracts that are combined. That's the fornix and the stria terminalis, and they connect the hippocampus and the amygdala to the hypothalamus. Now, we believe, based on prior work, that the Cingulum Bundle in yellow and the fornix and stria terminalis shown in yellow provide excitatory connections between the brain regions that they connect. The Unsonic Fasciculus in green provides inhibitory connections. Now, with the data that we see when we look at the strength of these white matter tracts, what we find is the purple white matter tract and the one in orange, as the strength of those connections increase, so does the expression of post-traumatic stress symptoms. So stronger white matter tracts in the Cingulum Bundle and in the fornix and stria terminalis lead to greater symptom expression related to post-traumatic stress. In contrast, the white matter tract in green shows the opposite pattern. The stronger these white matter tracts, the less symptoms of post-traumatic stress are observed. So what this suggests to us is the white matter tracts that connect these brain regions influence the symptoms of PTSD that are expressed. And the patterns fit with what we would expect from the literature and the excitatory and inhibitory connections between these brain regions. Now, one other type of imaging that we use in the lab is magnetic resonance spectroscopy, and that allows us to look at the biochemicals that are in the brain. And these biochemicals can allow us to look at things like the health of neurons in the brain. It allows us to look at energy metabolism, to look at cell membranes. But importantly, for what I want to present today, it allows us to look at this substance called GLX. GLX is looking at a combination of chemicals called glutamate and glutamine. And we generally think of them as an index of the amount of a neurotransmitter that's available for communication between different regions of the brain. And this is an excitatory type of neurotransmitter. And what we find is if we look at that dorsal region of the prefrontal cortex, that same region that we saw was showing deficits in safety learning, and one of those regions that was connected by those white matter pathways I talked about on the prior slide, what we find is that the amount of GLX in this region seems to be related to the severity of post-traumatic stress symptoms that are expressed. The greater the amount of GLX in this region, the greater the post-traumatic stress symptoms, suggesting that this aspect of biochemistry in the brain influences the symptoms of post-traumatic stress disorder. So let me try and pull all this together and summarize what I think these studies are showing for us. First, we think that there's an important neural circuit that is important for emotional expression in everybody, whether they're suffering from PTSD, another emotional disorder, or whether they're functioning relatively healthily. In terms of PTSD, we're seeing a lot of differences in function within this dorsal medial region of the prefrontal cortex. We see deficits in safety learning here. We also see that GLX concentrations, reflecting the amount of excitatory neurotransmitter, shows differences here that vary with post-traumatic stress symptoms. So it's a good sign that this is a region of the brain is probably involved and supports the development or underlies the development of post-traumatic stress symptoms. Also, when we look at the white matter structure connecting all of these brain regions, we're seeing variations in that white matter, the strength of it, that fluctuate with the severity of post-traumatic stress symptoms. So we think all these different aspects, brain function, the structure of white matter, and brain biochemistry probably work together to influence the post-traumatic stress symptoms that are ultimately expressed. And these might be some beginning levels of information that we can use for future studies that will hopefully allow us to improve the condition for those people suffering with PTSD. All right, so I'm going to wrap up there, but I want to quickly acknowledge the members of our research lab that have put a lot of time and effort into doing this work. That includes Heather Dark, Trip Ferencz, Adam Goodman, Nate Harnett, Mariah Wheelock, and Kimberly Wood. Also, we have collaborators, one at Auburn University, Meredith Reed, Adrian Lottie, the director of our CNC that we heard from earlier, who helped us figure out how to do the magnetic resonance spectroscopy data, and certainly Amy Knight, who's been critically involved in all aspects of the study. And you're going to get the pleasure of listening to her as she tells us about some of the implications, the clinical implications of PTSD. So let me stop sharing. And Amy, you can go ahead.
Can you hear me? Wonderful. Okay, so I'm not going to talk through this schematic. It's only here to show you the challenge then in the clinical setting of how to take the bench to the bedside, right? So we want to take the information we're learning and translate it to make it applicable to the clinic, and how we can take all this information and apply it to the clinical tools that we have today, because we certainly have plenty of patients with acute stress and trauma, and certainly some with PTSD. So my goal here is to just give you a little bit of a snapshot of my approach clinically with these patients and some of the stories that really do resonate in terms of making a difference and having people manage their symptoms, recover the best they can, and return to as much of a normal, new normal as is possible. So I want to also just back up for a second and show an example of things that all stress can come from. You know, we've all been there. This is a microphone and this is my public speaking moment. Now, some of us may be a little bit more nervous when it comes to public speaking. Some people are just real comfortable and don't care that much. We can appreciate there is a range of stress depending on the topic, depending on the audience. Is this a job talk? Am I among friends? Is this a peer group? What's the audience? Is it hostile or friendly? We also know that there's human performance variation based on the level of stress. And industrial organizational psychology will talk about optimal performance in terms of having just the right amount of stress. So for example, if I'm giving a talk, I want to have enough stress that I don't blow off the talk and not have slides and be unprepared, but I don't want to be so stressed that I move into a full-blown panic attack right now and not be able to finish. So it's pretty clear from the optimal performance with just the day-to-day stress that we all experience, there is kind of a middle level that helps us feel more energized and focused. It keeps us engaged. And when we think about COVID, for example, there's a certain amount of boredom that came with not doing enough with COVID potentially. And then certainly the other end of the spectrum where we've been potentially very fearful and overworked at times. And I'm going to address a little bit about that in addition to talking about PTSD today. So here's a more traditional stressor. If you're walking through the forest and you take in the big old rattlesnake, you hear the rattle, you are going to move into a fearful state for a good reason, right? Fear in the moment is about survival. And that's a little bit different than anxiety, which is the anticipation of fear. So the fear is going to help us in the moment, and our anxiety is going to help us later. So it helps to look at both of these things. So let's break it down for a second. And this is also real important as part of the education around PTSD to say this biological response has a purpose. It is normative, it is protective, it is necessary. And when you have a stimuli that is threatening, that is quickly processed through the thalamus and the relay to sensory cortex, through memory systems, then the hippocampus, and then threat detection through the amygdala, that is going to prompt an important response. We're going to need to stop and freeze, pull back, move carefully away from the snake, look around and find a safe path to exit. It also is going to sustain itself. So the difference between fear and anxiety is in the moment you have the triggering response and all those stress hormones that will sustain the stress response. We're going to need to get out of the forest. There may be many more snakes ahead. We're going to want to be on edge and to put the whole system on notice that the world is a very scary and dangerous place, and we need to be safe. We need to be careful. We need to look for more threats, if you will. And this is where I really take a minute to focus on the benefits of this system. This system is here to keep you safe. And we can talk a lot about prefrontal dorsolateral cortex or amygdala, but from a patient perspective, it helps to really break it down into something that's very concrete and tangible, something that can be easily recalled in a moment's notice. We know that some of the PTSD symptomology really shuts down critical thinking skills, so I want to make it real basic. And then this is where it's David's favorite part. Dr. Knight loves the puppet show portion of my talk. So if you take a look at our amygdala and our limbic system in there, it's going to look a little bit like a lizard. So I don't know if you can still see my face or my gestures, but go ahead and do your puppet show at home if you would like. I make all my patients do this. Put your hands together like a little lizard. That's your lizard brain. You all are a neuroscience population, probably don't love that sophistication, but it
Amy, we lost your sound.
Okay.
How about now?
That's good.
Okay. Did you hear the lizard brain part? That's really the most important part.
Unfortunately.
Okay, well, so David, just so I can make sure you understand, could you give me a lizard here just for, okay, funsies. So that's the lizard brain. And for our patients, it is helpful. Okay, enough of, you're done there. So our lizard brain is where our problem gets out of control. We have this fast, fearful threat detection system that is now generalizing. And enough with the lizard. So David's playing with his puppets again. What happens? So another analogy is to think of that barky dog that you have, the one that just goes crazy every time the mailman comes or the neighbor is walking their kids across your driveway. That dog knows nothing more than danger and threat and bark, bark, bark. And the way to soothe the barky dog is to take some control back, knowing that the lizard brain will get out there first. What we need next, okay, David, now you can do this is monkey paw. Okay, so on the other hand, we have monkey paw that sits on top. This is your prefrontal cortex. Okay, and that's, thank you. So it's a really helpful just reminder to say the lizard goes first, but with your monkey paw, you're going to calm your lizard down. We're going to talk about some treatment strategies. And the goal here is to really come up with some other options. From the research we do with the neuroimaging, it would suggest that we have some disconnection between frontal cortex and our limbic system. It would suggest that there is a failure to attend to other options in our environment, that it is not just a scary, dangerous place, that they are potentially sticks in the woods, they aren't all snakes. So how can we retrain our brain to reconnect in real time with therapies that we have available now to help our patients understand the disorder as protective, but also as maladaptive at this point, and really to be willing to go through the task of retraining and to deal with the uncertainty of the world, but be willing to slow down our thinking. Frontal lobe takes a little bit longer to kick in and gives us an opportunity to review our options. David already mentioned our patient population, the patient population that I work with, drawing from Spain Rehab. We see an awful lot of terrible medical injuries. Some of them are burns and crushes. One of the things I just wanted to point out that makes the symptoms far more likely to persist is the reality of that car accident. Maybe you don't walk away from it. If you have lingering injuries, if you have permanent disability, if you have pain, or say you have to go back to the job where you were pulled into machinery, or you caught on fire, or you were crushed, those are all very salient triggers, and they are not irrational. It is dangerous to drive a car. It is dangerous to work in prisons, in law enforcement. It is dangerous to work in many of these industrial settings. So it is not the case that these threat appraisals are unrealistic in some ways, but they are not the only outcome. So the therapies in all of these cases are really looking at the fundamental role of addressing some of the key symptoms of PTSD. So David already presented some of this, which is the exposure and the intrusion. So just recurrent thoughts of the injury and nightmares at times. The other criteria for PTSD are also our treatment targets, avoidance behaviors. I'm not getting back in that car. I'm not going back to work. I'm not going to Walmart. For some reason, Walmart is really scary. Negative thoughts like this was my fault or this was your fault, and feelings of just preoccupation and difficulty controlling those thoughts. And then the reactivity, the exaggerated startle response. So those components give us clear targets for some of our interventions. The research that we've done also gives us an idea of how important it is to factor in the retraining aspect and the importance of relearning safety signals and what it means to process safety cues. And so how we do that. I also just wanted to give a shout out to COVID here, right? So if we talk about injury that's happening in the moment, what about death, right? That's certain. It's the timing, however, of death that's a little fuzzy. And this is where something like COVID really does catch almost all of us somewhere along a continuum. We have this anxiety, which is a fear of, we have worry about what could happen and all of the intolerance of uncertainty that that anxiety brings. So there is the spectrum here of PTSD tells us an awful lot about all of our anxiety disorders. And similar to PTSD, we may have maladaptive coping. So things like avoidance that comes from not doing, not going, not living, avoidance that comes from substances, say, drinking or other illicits. And then conversely, we know that the treatments really center around good coping, which is basically not avoidance, right? So we need to get out there. We need to continue doing what we can within reason, within some safety parameters. We need to be able to talk about what we're feeling and thinking and what we want to do, and how we are processing not just the catastrophic failure to see safety, right? Not just the catastrophic threat signals everywhere, but also to consider some other options. How might it be safe again? How can we feel more comfortable with that? So just to conclude here, I wanted to give you a little bit of framework around some of the treatment steps with PTSD in particular, but also just generalized anxiety, and really just for all of us in getting back to normal. It helps to have some education on what it is and why it is. It helps to normalize it and to draw it into this continuum of stress reactivity. And there's good stress and there's bad stress, and it is part of being a human. A big part of relaxation is some skills training. So I routinely teach breathing exercises, progressive muscle relaxation, visualization skills. And then one of the primary treatment techniques is to look at avoidance behaviors. We really want to make sure we're working towards exposure. Exposure is our key behavioral component. And that's where the idea of subjective units of distress comes in. We want to do baby steps. We want to build mastery and confidence. This is a neurologic condition that needs to be brought back under control step by step. And subjective units of distress is a way to do the gut check. Are you ready to go to Walmart yet? That may be a bridge too far. So we're going to start at the dollar store. It's closer to the house. We can go in and just get one thing, but we're going to work our way up to something that's a little bit more challenging. And I really stress to my patients that bravery is not the absence of anxiety or fear. It is the willingness to be uncomfortable, the willingness to move into a growth position in order to gain mastery, in order to gain a sense of safety. That requires practice, and we are going to start slow and low, and we're going to build towards success. And we don't want to overdo it. If we overdo it and we have some panic symptoms, that's okay. We have regulation skills to de-escalate panic. We know where our boundaries are. We'll back it up a little bit and we'll keep going. It is also challenging some of those extreme thoughts and getting us back into our frontal lobes. Let's process what our monkey paw wants to do, not just what the lizard wants to do. That lizard will get away from us. We can reach out and grab that tail and pull it right back, make some other choices, and think through some other options, looking at alternatives. And ultimately, it's okay to be sad. It's okay to be anxious. Normalize the emotions, process it, not to be afraid of having the feeling, but not let that dictate our behavior. And ultimately, looking to establish new normals, sense of safety, sense of community, confidence, mastery. So that is the end of my presentation. So I hope that was helpful to give you a little bit of insight on what we do clinically.
Well, Amy and David, thank you for excellent thoughts. I think you've done a great job to make this concept very available to everybody. So we're going to open to the discussion now. So I would like to know, please ask your question. You can ask any type of question. I see that Tim Gunn.
Okay, so first of all, when you're doing the lizard brain and whatnot, and you said, on the other hand, that is an absolutely unforgivable pun. Shame on you. The couple of questions, the white matter stuff, I find this, you find differences in white matter tractology. So my question is, do people with different white matter connectivity have different responses to stress, or does stress cause differences in white matter connectivity? And how on earth can it change something that would seem to be so locked in, assuming you've controlled for things like, blunt force trauma and shock, which of course is going to change white matter connectivity. What is the deal with that, really?
Yeah, so we do try and account for head traumas. We exclude people who have had head injuries, loss of consciousness, anything like that from these studies. So there are a number of possibilities. So maybe some of these differences could be pre-existing. We can't rule that out at this point. We need longitudinal studies. It would be ideal. One of the ways that research is moving in some studies right now is looking at first responders when they're getting trained to be first responders before they've been exposed to the traumatic events, and then following them afterwards as they start to see people who get burned or people who've had accidents and things like that. And those kinds of studies would allow us to answer some of the questions that you have. Now, I think the other question that you were alluding to is, well, a lot of us look at brain structure and we think about it as being something that's kind of permanent, that doesn't change very quickly. And I think we're seeing more and more studies that show that both gray matter structure and white matter structure does change more quickly than we used to think. And in a matter of weeks, people are showing differences in white matter and gray matter. In the PTSD literature, there's not very much research that's looked at the brain acutely within the month after they've had a traumatic event. Our study hit them at about 3 weeks. We were aiming for less than a month, and we were getting them about 3 weeks. And we're starting to see some changes at that point in gray matter that I didn't talk about today, but within the hippocampus and gray matter, and in these white matter tracts as well. There are studies that happened slightly earlier than ours at about 2 weeks. Different groups, they don't show differences at 2 weeks. Now, this is a little bit speculative, but maybe that's too early to see the differences. And then there are other groups that have looked later, more at 4 weeks, and they also see differences that qualitatively seem a little bit stronger than what we're seeing at 3 weeks. So if you look across these labs, it looks like there might be things that start to change maybe at the 3 to 4 week level post-traumatic event. But keep in mind, that's looking across studies. It's a little bit speculative, and we need more research to really figure that out.
Oh, cool. The other question is, and this is even more off the wall than what I usually ask, I'm channeling my inner Klingon. Is revenge cathartic? If someone suffers an injury and somehow can either take revenge on the injurer or perhaps more neutrally regain mastery over the situation, is that to some extent helpful?
I assume that one's for me and not the other Dr. Knight. So those are actually two widely different scenarios, right? To get some control over a situation, absolutely. Revenge.
Well, it isn't. It there in some way it's mastery. It means if someone's beating you up and you beat them to a pulp and they stop. Well, you now have the same mastery as if there's something inanimate that you've stopped hurting you. It's control, different level, but fundamentally the same. It's control.
So control is, I think, central to the development of the stress response. If you are fearful and then fend off your attacker, I don't know that you necessarily are as prone to get a PTSD reaction as the diagnostic criteria, which really does imply a deep sense of lack of control, helplessness, and fear that you will not be able to survive and defend yourself. And that is what generalizes to a lot of other scenarios, the loss of control. And really almost everything we do in a treatment setting from a cognitive behavioral sense is restoring that sense of control. I don't advocate revenge therapy and
I
anger.
don't either. I raised it as a cognitive issue.
Well, if you take the parallel of, feeding into anger, right? And what is anger doing for you? Anger is largely a perseverative thought. Anger is something that becomes obsessive and preoccupying and not helpful, because truly you're not in control of anger. And so the mastery of being able to handle your emotions in a productive way that let you get back to work, that let you see the coworker again or the safety inspector that you somehow blame for the incident without retaliation, ultimately is the therapeutic course.
Okay, well, I guess I will hold off on learning Klingon just yet, but excellent talks, both of you. Thank you so much.
Okay, we have a question in the chat. Can you speak about the difference between PTSD and complex PTSD, especially when the trauma was an ongoing occurrence that took place during childhood?
Yeah, so I see the rest of that. So that was breaking up a little. I'll just comment briefly, and David, you may have more insight in terms of the literature, but trauma begets some trauma, and it's a very complex dynamic, but there are socioeconomic factors, and prior trauma absolutely is a risk factor for subsequent psychiatric reaction, subsequent PTSD manifestation. I usually tell my patients, once PTSD, always PTSD. You just gain better control of the symptoms and better management of how it affects you. But David, I'll let you comment a little bit more on, the ongoing impact of a childhood trauma, because I know that there's some literature around that. We can't hear you.
Not hearing me is probably for the best. So, I would say in general, the way that we think about childhood trauma in terms of when the brain is still developing, that a developing brain is likely to be more susceptible to a whole range of insults. In this case, psychological insults, not physical, but it would be true for physical insults as well. And certainly from sort of a learning perspective, things that happen repeatedly are associations that tend to be learned more strongly than events that happen just once. And so from a basic learning and memory perspective, we would think that things that happen frequently and repeatedly are going to be learned and form stronger associations than things that happen only once. Obviously, there are caveats, but.
I guess I just want to add, there's another analogy I give with my patients. Your brain would be adaptive if it was the zombie apocalypse here and the world was a terrible, scary, and dangerous place that you need to be fearful of everyone and everything. You can think of childhood abuse as a zombie apocalypse. For that child, their experience, the world is a dangerous place. You cannot trust safety cues. You do need to be on edge. There are some adaptive aspects of the stress response that are, understandable given the environment.
Great. There's another question in the chat. Do you want to look at?
Sure, I'll read it. There was some discussion about holding a traumatic experience constant. Different individuals may or may not develop PTSD symptoms. What is known about neurobiological or other factors that predict who will respond to psychotherapy treatments? Well, regarding the treatment, I don't know about the neurobiological factors of who will respond to treatment. There are certainly factors that influence the development and make it more likely, both premorbid characteristics as well as characteristics of the trauma, the extent of the injury, persistence of disability and pain, for legal action. Also, all of those things can roll up to make things more likely for symptom expression and potentially more resistant. I mean, certainly I see a lot of folks that are workman's compensation, and the presence of some amount of secondary gain, in addition to the priority about going back to a workplace that harmed you, make those cases more challenging. But generally, I can't say that I know of research or even in my personal experience, anything that distinguishes treatable versus not treatable. We do what we can.
I honestly don't have a whole lot to add to that, but I will say there, with stress research more broadly, and this is something that Amy was referring to earlier in the conversation with Tim, is that things like the predictability and controllability of threats impacts the way that we react to them. And so I can imagine scenarios where, people who feel like they have more control over the world around them may respond better to therapy. People who feel like threats in the environment are more predictable might do better. This is speculative, but there is good data that suggests that those things impact how we react to stress. In terms of the neurobiology, that research is still pretty new. There are some things that we've done in the lab looking at the predictability and controllability of threats. And we know that one of the regions that we were talking about today, the ventral medial prefrontal cortex, seems to be a region of the brain that is influenced by predictability and controllability. And in our case, it responds less when threats are both predictable and controllable than when they're not. And there's similar work in animal models by Stephen Mayer out at the University of Colorado, and he finds very similar things. He finds that the ventral medial prefrontal cortex is very important for supporting those kinds of processes. So if I were to give an answer about the neurobiology, I would suggest that that's one region that we should focus on in future work.
I see two hands. We see Leland Keller. Do you have a question, please?
Yes, a question regarding a person, an elderly person who's exhibiting symptoms of panic attack, who otherwise seems to be fairly normal mentally, not dementia or anything. Just wondering what the best approach that the family and friends have towards this person.
Sure, let me grab that one. So panic attack is incredibly common. It's probably the most common kind of psychiatric experience that is as dramatic as a panic attack is, that most people may encounter in their lifetime. And sometimes they're transient, sometimes it's a one and done situation. Sometimes it represents a pattern and it seems to be getting worse or more frequent. The main intervention for panic disorder is to work on your, again, mastery of getting through a panic, right? To understand that a panic will typically last 15 or 20 minutes, to learn some of the meditation skills, some breathing skills, to recognize that panic is happening and to just start breathing, have a seat, calm, gentle thoughts, but to not give in to panic. So the most important thing with panic disorder is to not encourage avoidance, right? To not go get an alcoholic beverage to calm down or necessarily a Xanax to calm down, to start getting more comfortable with that situation was disturbing. What were some of the factors that might make it easier, but to not avoid a situation, right? So if I had a panic, again, in Walmart, seems to be very popular for panic attacks, you still need to go to Walmart. You maybe need to ease your way back into it. If you're having a panic attack, calm down first, but then go ahead and check out. So it is, again, panic disorders will get worse if you feed them. So just to be careful with that. And to just encourage people to, process and go on business as usual as best you can.
Great, thank you.
Thank you. I mean, there's also a hand raised. Jessica, Asvin, you have a question?
She was just waving. Hey, Jessica.
Hi. So would you consider what people are experiencing now with COVID to be part of PTSD, or does it have to be post-event to be considered PTSD?
So they actually, DSM-5 loosened PTSD criteria. So it can be, you don't have to be experiencing the event itself and immediate harm. So there are aspects, I think, of COVID, and it certainly is the degree to which if you had COVID or if you had a loved one with COVID, it could very well qualify. I think it's less applicable for kind of the generalized angst that most of us have with COVID, but it certainly fits aspects of the anxiety disorder. It looks a little bit more like a generalized anxiety disorder, borderlining on people that don't ever want to leave the house again, and some difficulty with returning to normal. So it broadly fits within a number of anxiety disorders. Really, for most of us, it would just be kind of an adjustment reaction because we are all still just doing the best we can. But I think it just depends. And largely, I don't know that it matters. All of these anxiety disorders do need to be kind of addressed step by step, baby steps. Let's get back to normal. Just calm down. Let's think through. If we have some catastrophic thinking, let's come up with some other options. Best case scenario, maybe less catastrophic scenarios. What's it going to take to get back to safety? So, I think it's possible, but I also think there's plenty of other anxiety disorders to qualify here.
Great, thank you, Amy, again.
Thank you.
We have another raised hand, Tim, again.
And with Tim.
Question for you. This is all mostly post hoc. We know that some people are naturally more resilient than others. Can this be learned? Can this be trained? Can you learn to be more resilient through specific training or experience?
Sure.
To some extent, the military does this all the time. The people there experience things would drive us crazy, but because they build up to it and you get exposure. But it tends to be task specific. Is there a way to create resilience before the fact? Can this be learned in a general sense, not just task specific desensitization?
Well, I think you're talking about self-efficacy and a degree of locus of control, to be internal with your sense of mastery of the world or your capacity to master a new task. Again, returns to this concept of self-efficacy. Do you feel like you are capable of handling a thing? And that can be trained, and it can be trained task specific, and it does generalize some. So that is, I think, always what we are doing in education, in any of our settings, is helping people learn new material, gain confidence, and ultimately feeling better about themselves and transferring that to another situation.
Huh, okay.
Okay, we have another night person raising hand. Adi, do you have a question?
Hi, yes. So I wanted to ask, are there like differences in how the PTSD presents depending on the kind of the type of trauma?
Good question, Addie. No, I don't think so. I think one of my favorite, if it's fair to say, a favorite thing about PTSD can have a myriad of symptoms, but it, and various degrees of, some people are more nightmares, some people have more, anger reactions, but it really does fit. It really is fairly reliable in the scope of its presentation. And I do think that any of us would be vulnerable to developing PTSD. I don't think it's a premorbid conclusion that some people get it and then other people would never get it. I think in the right circumstances, under enough pressure and trauma with subsequent disability and pain, any of us might develop PTSD. That being said, I have seen people that have had very minor to my estimation, because I have seen horrific accidents and devastating injuries. They don't look much different to me.
So I just want to add to that. Yeah, I think what Amy's saying is absolutely right. There is research that's not specifically PTSD, but related to other types of violence. So it might be violence broadly defined. It might be physical abuse. It might be sexual abuse. And some of the research out there has started trying to tease apart whether there are different behavioral effects for physical abuse versus sexual abuse, for example. And I don't know that literature very well, but I know enough that there are some differences that people are finding. And so, for example, maybe people who experience sexual abuse are more likely to get one type of diagnosis. Those who have a lot of physical abuse might tend to get a different type of diagnosis. And their symptoms kind of fluctuate a little bit based on the type of abuse they've experienced. We've been looking at a little bit at that with neuroimaging research. And one of the things that we're finding in some of our studies is that we are seeing areas of brain activation that vary much more strongly with sexual abuse than with physical abuse. And honestly, I'm ashamed to say I don't remember exactly what our results are, but we'll just let it stand that we see stronger relationships with sexual abuse than physical abuse.
I would also add, anecdotally, I don't have evidence or research to back this up, but burn is devastating. If you have sustained a significant burn, that seems to be a more pronounced symptom expression and just of a more persistent duration.
Are there more questions? I don't see anything on the chat. I don't see raised hands.
Well, just your minor thing. You'd mentioned burns. Fortunately, I've never had a large area severe burn. I've heard they are some of the most painful wounds ever, suggesting that maybe you should really go heavy on the painkiller with burn victims.
Well, the problem with burns is you have burn dressings that limit, I mean, there's only so much pain medication you can give safely, and you have regular burn treatments and wound changes. And that is part of the trauma, is that you are re-traumatized every 2 days. And there's only so much narcotic that is possible over that.
Well, local anesthetic. You raise an interesting question. I had heard in the past that there's something particularly nasty about severe burns. Maybe this should be a priority area of research, how to do the dressing changes in a least traumatic place. Might be particularly valuable. Just
sure it would be.
Random thought.
Yep,
but
you're right.
Again, I'll shut up. Awesome talk. Really, really outstanding. Thank you.
Thank you.
Well, we are really very lucky to have experts like Dr. Knight, both of them at UAB, and be able to explain to us not only the brain implication, but also the clinical way to address those symptoms. So thank you very much for really, really good talk. And thank you for people for coming. I think it's great to have such an interactive audience. And remember, this is recorded and it's available on our website. So if you type UAB CNC for Comprehensive Neuroscience Center and look a little bit at our website, and you will be able to look at this recording and speak about it to your friends. There's a last question. Are you all aware of the ongoing research at Hopkins on the psychedelic assisted therapy to treat PTSD and other psychiatric disorder? Yeah, I think this is getting to be a hot topic. It was very much in the news lately, but hopefully we can have one day Dr. Hendricks, who is at UAB and who is really, an expert on psychedelic drugs.
When I saw you had a cannabis talk coming up, so.
Yes,
There
absolutely.
you go.
Okay, well, thank you very much all, and we'll see you next time. Have a great evening.